Hi, I had no disclosures. I'm John Lesser, and I do CT and MR at the Minneapolis Heart Institute. And Paul told me to talk about nuances, which is an interesting way to start. But speaking of start, okay. Here we go. So for CT, image quality is preeminent. And you may have patients who are sick, with a rapid heart rate, no beta blockade. So you have to choose your data set for analysis, where the first priority is to reach an image quality threshold that allows for a reproducible measurement. CT acquisition very much depends upon the hardware qualities of the scanner, and you may not have a full understanding of this, but the better the temporal resolution or the shot time, the more likely you're going to stop motion. Also, heart rate and rhythm interact with this issue. Now, we know that the aortic valve has a dynamic annulus, and then here in a retrospective study of 507 valves, both the area and the perimeter were dynamic, and that if you only measured in diastole, 30% would have a different valve size. So when we try to create the proper image, we need multiple data sets to select at the systolic interval. And here's an example where we want to stop motion, but it needs to be at the largest annulus. So at 35%, it was 4.5 centimeters squared, and at 25% is 5 centimeters squared. And it could even be larger, and it's not even given to us when we're analyzing our data. So can you acquire a proper scan and still underestimate the annular size? And what we've seen in patients with a low stroke volume is they may actually open the valve early. So a very early point in systole may be the largest. And here's an example where at 15%, it was the largest data set. And then when you look later that someone from industry could say that the annular area was different than what you've gotten, it may be a different interval that's being measured. And that's a very important issue, even with good image quality. Now, there's a second scan in this where you do the heart and then you do the chest, abdomen, and pelvis. When you do this, you may randomly get a systolic image. But that's not good enough because we need multiple data sets in systole. And on the bottom, you see that you have a diastolic image randomly captured, but the actual annular size is significantly larger. So we want to minimize contrast in a lot of these people, and how do we do it? And there are multiple ways. The first way is to lower the KV, and that allows for an increased contrast to noise. As a result, you're able to decrease the injection rate and contrast volume. You can get an adequate chest, abdomen, and pelvic scan with 30 to 40 milliliters, but you can't get the systolic intervals except for using about 50 to 70, but again, it's patient size and scanner dependent. What about alternative imaging approaches? One is to use no contrast and no CT. That's one approach, of course. A second is what we do, is we try to use everything that's possible. And so we'll do 3D TEE and IVUS, but we also do a non-contrast chest, abdomen, and pelvis, and a cardiac CT. And what you see here on the right side, the external iliac was an adequate size, but we don't know just from this whether there's non-calcified plaque causing a lesion, so we IVUS the right. But on the left, we saw by CT it was too small, so it can't be bigger than that, so we just left that alone. The other approach is, can you get information from the non-contrast CT that's useful? And you can. Here's what we used to do in about 2011, where we made a thicker cut. We actually got right through the right coronary cusp, and you can actually get adequate angles. And if there's enough fat, you can create a plane that allows you to see the sinus of Valsalva and even the coronary height. It's not reproducible, though. What about cardiac MR? We do this frequently, not for this indication, but there's something called a navigator and ECG gated sequence that has no gadolinium and it's free breathing. Unfortunately, it's only accurate in diastole. And you need a relatively regular rhythm, and you can apply a correction factor that allows you to make something like systole, but that's really not good enough. So we almost never do that. Now, what about after you have the scan? You need to window properly so you make accurate measurements. If you look on the right, external iliac here was considered 5 millimeters. But just by applying an increased window and level, it increases to 5.6, and that's blooming from calcium. That's very important to recognize. What about edge detection from the software? Here it looks like it's narrow, but we just use that as a screen, and then see lower, do a manual cross-check, and see that it's actually much larger. CT measurements need to be standard and reproducible, and you should have a perpendicular point from the annulus up to the coronary, and this is reproducible. The same is true with the sinuses. You need to go from cusp to commissure. Now, we know about coronary obstruction, about left main height, sinus valsalva diameter, and both, But there's another thing in that paper that might be useful for any single person, and that's to look at the sinus of Valsalva mean diameter over the annulus mean diameter, and it may be helpful in any one small person. Now, when we report calcium, report the part that's predictive of injury. The upper left ventricular outflow tract, the 2 millimeters beneath the annulus, are more predictive than the overall left ventricular outflow tract calcification. Also, the non-coronary cusp is more predictive of injury than the others, and it's predictive potentially of pacemaker need. If you measure the membranous septal length, if you have a length which is easy to measure on the AP view, it shows you where the bundle branch, right bundle is and where the His is. And if you have a length that's under 8 millimeters using a self-expanding valve, you have a much higher chance of getting heart block. And it also occurs with sapien valves. And here's an example of one of ours with a 5 millimeter septal length who required a pacemaker. Bicuspid valve, it's easier to see on CT. And one thing to remember is to tell people when you have a fused calcified median raphe, that may become a stalactite, and it has the potential for injury. So that's worth commenting on. Now, we can get angles from automated software, but it's where you place your dot in the cusp that shows where the line will go between the other two cusps, and it may not show it in the cath lab very well. So we do a manual approach. On CT, you're looking AP. On the cath lab, you're looking PA. So we see the right cusp very well. You may see it less well in the cath lab. You should probably just believe us. Okay, and then you want to check the angle for accuracy. If you're tilted on the table, a lot of the people we do have kyphoscoliosis, but you want to be able to scan down and see the table itself and the patient's back, and this is not expanded enough for us to tell why this is this way. There are alternative access sites. You just need to know how to use the software, look for calcification, and decide whether you need to go intercostal or a hemisternotomy. And the same is true by using clip planes to see about where the valves are relative to the ribs. Now, I think this is one of the more important things, is looking for tilt in valve and valve. And it's the two things, the tilt of the surgical valve, and then how is the sinus and how does it accommodate it. And here's one that's heavily tilted. And then you can see you place the virtual THV and make a determination of risk. So our imaging nuances here are that the CT acquisition goals are to stop motion, create early and multiple systolic data sets, and have multiple ways to deal with renal insufficiency, window properly on the workstation, reproducible approaches, and then report on the subtle issues that I talked about. So thank you.